Hello everyone. You are welcome to CME organized by Kurunagala Medical Association. Today, we have an interesting presentation on post-COVID-19 vaccination era, where we are heading to. This activity is already recorded. Dear colleagues and doctors, it is my great pleasure and privilege to introduce today's speaker, Dr. Muditha Abeykoon. He obtained his MBBS in 2001, MD in medical microbiology in 2011, and working as consultant clinical microbiologist. His area of special interest are milioidosis, neglected fungal infection, and invasive aspergillosis. We are proud to have this young, energetic, and enthusiastic clinical microbiologist at Teaching Hospital Kurunegala. We welcome you, Dr. Muditha Abeykoon, for this presentation. Thank you.
Good morning, everyone. Today I am going to talk about post-COVID-19 vaccination era. Where are we heading to? Before starting the lecture, I would like to thank the President of the Kurunegala Clinical Society giving me the opportunity to deliver my speech on this topic. I know for last few years you have been hearing lot of talks about COVID-19 infection. My topic is a bit different today because I am going to talk about, as you all aware now, we had a very successful vaccination program throughout the world. So because of that, after the COVID-19 vaccination, how our world is going to look like? Are we going to the normalcy very soon, or even with the vaccination, are we going to face the same difficulties we are facing now? So are we going back to the normalcy soon? Can we open cinemas very quickly? Can we start schooling? Or can we have mass gathering like we had before, about 3 to 4 years ago? Or are we going to see the same pictures we are seeing in the world today for a few more years? Unfortunately, I don't have a very robust answer or a definite answer for this. So it is still a big question even in the post-vaccination era. Before starting my proper lecture, I would like to remind what pundits, I mean basically the main virologist, predicts at the beginning of this COVID-19 pandemic. Like Professor Malik Piris, who is a very renowned virologist, and I am proud to say he is a very proud product of Sri Lanka and from the Peradeniya University. So all of them predict that this battle never going to be a 100-meter race. And also we know now, after living with COVID for nearly 2 to 3 years, unfortunately, it is not a middle distance running as well. So it is going to be a marathon. How long and how many years we are going to run with the COVID-19, only God knows. Right. Before that, I would like to divide this pandemic into two main categories. So if you take the evaluation of this pandemic COVID-19, we all know when it started late 2019 in China, we never had a vaccine for COVID-19 disease. Initially the disease was with the wild type of virus, and at that time, at the beginning it was China and then the countries in the Europe, how they try to fight with this enemy. So what were the weapons we had? So we had this social distancing and lockdown, and unfortunately I have to say the main weapon at that time we had was this social distancing, and the most effective method of social distancing was lockdown. Then we had mask, and then we promote hand washing. Now, the second part of this pandemic. Now, as you all know, considerable amount of world population has been vaccinated with many vaccines. So now it is called the post vaccination era. But unfortunately, during this post vaccination era, our enemy also has changed. So we got a lot of variants. Now the dominant variants in the world is Delta. So what are the weapons at this moment we have to fight this deadly enemy? And the most effective and the most safest weapon at the moment we have is vaccines. But still, I have to mention, when we are trying to fight with this enemy, vaccine alone will not enough. So still we have to use the social distancing, lockdown, mask, and hand washing as well. So now I would like to go into the Worldometer website and see, after the vaccination, what has happened to the COVID-19 cases and what has happened to the COVID-19 deaths. Because we had a we were very hopeful about these vaccines, and even some of the scientists or some of the leading medical professionals, they predict with these effective vaccines, this pandemic is going to be over in about another 1 to 2 years. But unfortunately, I can show you with the statistics, still the cases are rising and there are still considerable amount of deaths happening in the world even after with very successful vaccination programs. So now you can see, if you take the country like Brazil, if you take a country like India, still the cases are rising. And even in the United States, even with a very successful vaccines, the cases are going up. If you take United Kingdom, one of the countries who had a very successful vaccine, their cases has drastically came down, but still it is on the rise. And now we move on to see what happens to the deaths. Now if you see a country like United States, still they have a considerable amount of deaths per day, and yesterday it was around 500 deaths per day. Brazil, it is the same fate. India, it has come down, but still considerable amounts of per deaths are happening there. And again I would like to mention the United Kingdom, where they had a very successful vaccination program. Their cases are going up, but they were able to reduce their death rate, but still around 100 deaths per day it is happening. So we had very 5 or 6 good vaccines available in the world at the moment to fight against this disease, but still there are considerable amount of deaths are happening. So where are we heading to during this post vaccination era? Unfortunately, all the leading virologists, microbiologists and scientists, they are mentioning all these vaccines are very good against preventing severe disease, but unfortunately the breaking down of the transmission cycle, when it comes to breaking down of the transmission cycle, most of these vaccines are not that effective. Because of that, even in the next few years, we have to expect the continuation of this transmission cycle. Because of that, the people who have comorbidities like diabetic, renal disease or heart disease, those people, there is a high chance of getting severe disease. So even for next 5 to 6 years or even for next 3 to 5 years, we will see the transmission cycle of the viruses. We will see people who get infected with the COVID-19 vaccine, and unfortunately, we will see deaths as well. So that is the simple answer for my question, where are we heading to? Later in my lecture, I will describe those things in a comprehensive way. So before that, I think we need to refresh our knowledge about COVID-19 disease. So as you all aware, COVID-19 is SARS coronavirus 2, which is a novel virus which was initially found in China in 2019. So because of that, we have to talk about coronaviruses. As you all know, this is a well-known RNA, positive strand RNA virus, which were with the humans for many years. But fortunately, it infected the upper respiratory tract and the gastrointestinal tract of the mammals and the birds, and especially when it comes to humans, up to 2000 it caused very mild disease. It is named as coronavirus because it is an envelope virus and it has spiky proteins on the envelope which look like a crown. So the name means crown. The corona means crown, and it transmitted via large droplet, respiratory droplet, as I mentioned before, usually causes mild upper respiratory tract infection, and it can cause gastroenteritis in children, and this is the second most common cause of common cold after rhinovirus, and it causes around 10 to 15% of common cold, but very occasionally it has caused severe disease and pneumonias. But after 2000, the history of coronavirus changes dramatically. That is because of the SARS virus, which is called severe adult respiratory syndrome. The history has changed of the coronavirus because of the SARS disease, which occurred in 2000, between 2002 and 2003. Severe acute respiratory syndrome, or the SARS. So what was SARS? As I said before, usually coronavirus cause mild upper respiratory tract infection, but unfortunately in 2002 there was a novel coronavirus which caused a severe lower respiratory tract infection. It was first appeared in southern China in November 2002, and we are very glad to say that this SARS virus was initially detected by a Sri Lankan virologist who is working in Hong Kong University at that time, and he is Professor Malik Piris. So this virus was found in civets, a cat-like wild animal eaten as a delicacy. So the initial focus of the virus was a bat, and the intermediate host was the civet, and the people, the human, got the infection because they have eaten the flesh of this animal. In 2003 March, the WHO organization recognized this severe lower respiratory tract infection as a global threat. It spread to 29 countries, had 2096 cases and 774 deaths, but fortunately it never triggered. Scientists expect it might be the next pandemic, but fortunately it never kicked off as they expected. So it was confined, I think, within about 1 or 2 years. And the second severe coronavirus encountered in this decade was MERS, which is the Middle East Respiratory Syndrome, and it was first detected in 2012 September in Saudi Arabia, and they thought the intermediate host was a camel. So the people who had very close contacts with camel got this severe lower respiratory tract disease. In all those instances, the SARS coronavirus 1 and the MERS virus, they had one thing in common. That is, the virus was replicating in a natural host. This coronavirus were replicating in a natural host. Usually the natural host is bat. So this is a natural phenomenon which is occurring in human history for thousand years. So these viruses infect bats or some kind of an animal which is specific to this virus, and they live in harmony. As you all know, viruses are either RNA or DNA particles, but unfortunately they don't have a cellular mechanism owned by themselves to do their own replications. Because of that, they have to, for their metabolic processes, they have to depend on another animal. So usually they infect their primary host and they live in harmony. They use the primary host cellular mechanism for their replications. But this whole story changes when accidentally, for this cycle, when come another intermediate host. And as you all aware, these viruses are all the time changing, which is we call in the scientific world as mutation. So all the time mutations are happening. So some strains of viruses can infect other intermediate hosts apart from the natural host. So when the replication occurs in this intermediate host, again the mutations will happen, and there is a chance these mutations which has been occurred in the intermediate host, if a human accidentally get into this picture, even these viruses can infect humans. During past two severe coronavirus infections, these viruses were able to break the species barrier. So they infect the intermediate host first, and then they were able to infect the human as well. But fortunately, when the replication occurred in the human body, the mutations or the replication process happened in the human body, the newly generated virions, they were not able to infect the humans successfully. That is why SARS coronavirus 1 and the MERS virus never became a pandemic. It was only, they were very severe, but it was only some sporadic cases. Again, elaborating on this topic, you can see these coronavirus usually primarily infect bats, sometimes in rats, then they come into intermediate hosts through mutations, and when the mutations are occurring in the intermediate hosts, if they are, and if some of the mutant virions are able to infect the human body, human cells, then it become an infection for the humans. So this natural phenomena almost every year happening in my environment. Almost every year, new respiratory diseases caused by new or unknown viruses, and viruses that we know well can cause serious health problems. The COVID-19 pandemic is a typical example, and it surprises even the greatest experts in infectious disease and public health field. But unfortunately, I have to mention this natural phenomenon was happening in the environment for many years, but unfortunately World Health Organization or the expert never anticipated this event will happen in this century. So we knew this is going to happen some point, but these experts never anticipated that this will happen this soon. Another important point is we cannot and should not assume that viruses we have known so far will not return with even greater force in the future, because as I said before, this is a natural phenomenon even now happening. So what we should do? We must be prepared for these events in continuous research, development and new diagnostic tests, and with the development of new antiviral agents and vaccines, with the participation of specialists from different countries around the world. I think before doing that, first we have to get over this current enemy. As a human civilization, we all are facing it, and first we should get rid of it, and then I think these sort of comprehensive planning should be implemented via WHO to prevent future pandemics like this. So because of this, now this new concept has come into the scientific world, which is called the One Health. So there should be an institution under one umbrella where these free moving natural DNA or RNA particles should be monitored. It can be in animal, it can be in plants, it can be in agricultural field, or it can be in humans, but we should monitor them closely. We should monitor RNA and the DNA particles which is in the nature who have the potential of trigger another pandemic. So there should be one institutions where all those researchers has to be carried out under one umbrella. So who is the real boss in the world? Is it Joe Biden, the American president, or is it Xi Jinping, the Chinese president? Or is it the free flowing RNA and DNA molecules in the atmosphere? I think you know the answer now. So for ages, this has been the same story. So if you go into the history of this pandemic, so even at ancient time, so it is written that these pandemics or these epidemics were happening. So here you can see in Sinhala literature, in Buddhist literature, it says there was a disease called Ahivataka, which means this disease was spreading via respiratory tract, and it was originated from the exhale air of snakes. So when it comes to the today's science knowledge, we can quite easily explain it was the same phenomenon I have described few minutes ago has happened even in the ancient times. So when we talk about the human civilization, the persistence of the human civilization always depend on these viruses which can spread via respiratory tract. If you go into the history, it is the same story. You can see in this slide how many pandemics we have faced so far, and you can clearly see all these diseases except for cholera, they were mainly viruses spreaded via respiratory tract. Now if you take plague, it was a bacteria, but still it was a very virulent organism, mainly spreading via, I know the host is a rat, but if you take pneumonic plague, basically spreading happened via the respiratory tract. And I just want to mention, before the COVID-19 pandemic, the last pandemic we had in 1918, it was nearly 100 million people, between 50 to 100 million people died because of this pandemic. So you can see, if you compare the Spanish flu to the COVID-19 pandemic, the more virulent one was the Spanish flu. Right. I think I have talked about basic virological principles of this species crossing. I have so far talked about basically the basic features of the coronavirus. Now we talk about COVID-19 in bit detail. As you all know, these facts you might have already known. So this disease emerged in December 2019 in China, Wuhan, and then the causative agent was identified as SARS coronavirus 2. The WHO named the disease as COVID-19 on the 11th February 2020, and officially the World Health Organization declared COVID-19 as a pandemic on the 11th March 2020, and you can see so far globally we have nearly 45 lakhs deaths and nearly 200,000 cases globally so far. As I mentioned before, there were 4 human coronaviruses which cause mild respiratory tract disease before the SARS and the MERS, and this is the third virus, the COVID-19 or the SARS coronavirus 2 was the third virus which was able to cause severe pneumonias in human. And it is about SARS coronavirus 2, it is about 79% to 59% similar to the SARS coronavirus 1 and the MERS virus. And bit about the structure of the virus. As I mentioned before, it is a positive RNA molecule and it has an envelope, and in the envelope it has this spiky glycoprotein called S, and apart from that it has some other protein molecules which are named as E protein and M protein, and if you see some PCR reports you will see this E gene and M gene, and actually these specific protein molecules or specific genes we use for the identification of the virus when we are performing polymerase chain reaction. As I mentioned before, it is about 80% resemblance to the SARS coronavirus 1. So because of that, actually it has been named as SARS coronavirus 2, and we all know according to the phylogenetic studies the primary host or the ecological reservoir was bats, and intermediate host they suspect pangolins, but they haven't found the definite intermediate host yet. And the transmission, it is via droplets in short range up to 1.8 meters. And I have to elaborate on this one, the mode of transmission. With the emergence of new variants, and still the scientific evidence are still more towards still it is a droplet infection, but it differs from typical droplet transmission because these viral particles can hang on the environment, especially in close environment, for several hours. And when we talk about the variants, their viability on close environment is more, but still there is no evidence to name it as a virus which is truly airborne. So it is still a droplet, and the main mode of transmission is droplet, but its transmission is more when it compares to other common cold viruses because it can stay in the environment for longer duration. And the formite transmission is possible. It can stay in plastic environment for 72 hours, stainless steel for 48 hours and cardboard for 24 hours. Bit on the pathogenesis, it infects the epitheliums of the upper respiratory tract or the lower respiratory tract, and in virus it got this spike protein, and in the spike protein there is a special segment called receptor binding domain, and this receptor binding domain or the RBD go and attach to the ACE2 receptors in the human body. Especially these ACE2 receptors are in abundance. They can found quite easily in the upper and the lower respiratory tract. And then after the binding, the virus, as you all know, it is an obligatory intracellular pathogen. So the virus will get into the body and then it will evoke a cytokine cascade and inflammation, which is very, very damaging to some people who actually, the people who get the severe disease usually get the disease because of this cytokine cascade, and the incubation period is between 2 to 4. And my personal experience is when we had the COVID-19 outbreak and the first wave with the wild type, usually the incubation period was usually around 7 to 8 days, but with these delta variants and alpha variants, I think their transmissibility is more. So because of that, incubation period is less. Actually, I have seen some of the patients contracting the disease with the infected after the exposure for an infected person, even with 2 days of exposure. So this is what I have described earlier. So the viral receptor is protein, the receptor binding domain will come and get attached to the ACE2 receptors, then virus will get internalized into the human cells, and then it burrow the protein synthesis mechanism of the cells, and lot of viral particles will be produced inside the cells, and then after each cycle they will destroy the cell, and all the viral particles, newly produced viral particles, get into new cells, and this will carry on. Outcome of the infection still it would be the same. Still majority of people, they get mild to moderate disease, that is about 81%, and you will get around 14% of people will get the severe disease, and it is around 5% who actually get the critical disease. So the overall case fertility rate is around 2.3%. But with the emergence of this new variant, I mean, in some instances, the variants like Delta or Alpha, they have more virulence, but actually what is happening is their transmissibility is more. So because of that, the number of people who get infected within the same time period is more when it compares to the wild type. Because of that, because you get more people getting sick with the COVID-19 infection, I mean when the number is more, automatically the people who will get the severe disease also is more. So because of that, the hospital settings, not only in Sri Lanka, even the countries like USA or UK, they were not able to cater all those cases at once. So that is, I think, even with the variants, there are some variants actually which can cause severe disease, but what is mainly happening is because of their high transmissibility, lot of people get sick more quickly. So our health system gets saturated quickly. Because of that, we were not able to manage all those patients ideally. So I have talked about three coronaviruses now. One is SARS coronavirus 1, then the MERS, and the last one is SARS coronavirus 2, which is called the COVID-19 disease. So, why only COVID-19 became a pandemic? There are few main reasons. One of the main reasons why this became a pandemic is, I mentioned you, all those three viruses break the first species barrier. Usually their natural host was bat, and then they came to an intermediate host, and then from the intermediate host they infected the humans. But in SARS coronavirus 1 and the MERS virus, human got this disease from the intermediate host, but fortunately when the replication occurs in the human body, these virus, the mutations happen in these viruses. I mean, these mutants were not very successful in transmitting the disease from human to human. But when it comes to SARS coronavirus 2, the second mutation cycle which happened in the human body to cross the species barrier, actually these viruses were very successful. Because of that, they were able to, the viruses were able to infect one human from another human. So, viruses were able to, infect one human, and from that human, these viruses were able to infect another one. So, that is the main reason why COVID-19, SARS coronavirus 2 became a pandemic. Apart from that, as you all are aware, this virus is spreading to another person not only during the symptomatic period. It is found that pre-symptomatic period also this virus can spread from one person to another, that is 2 days before appearing the symptoms. So, usually the movements are get restricted of human beings once they become ill, but unfortunately here, even before they are getting ill, they are spreading the virus. Because of that, at the time we diagnose that this patient is having COVID-19 infection, he has already spread the disease for several other persons. Then the second point is, it is the same policy. The majority of people are asymptomatic or they have mild infections. Because of that, they carry their routine work as usual, spreading the disease to other people. So, why it has become a problematic pandemic now? Again, I just want to go into the worldometer and I will show you during last 2 years how this disease has spread across the globe. Now, I will play this slide and you can see since 2020 January how this SARS coronavirus 2 has spread across the world, and at the beginning it was the wild type of coronavirus 2. Now, you can see initially it originated from China, then went to Europe, mainly Italy, Spain, and then went to UK, and at that time the epicenter was UK. Then simultaneously it spread to USA and adjacent countries, then Brazil, and then it came to India, and now it has conquered almost all the countries in the world. I am talking why it has become problematic now. Now, you can see the most of the countries actually highly endemic to this deadly bug. So I have to mention this virus is very clever as we think about it, because initially the wild type cause mild disease in most of the people, and in about 1.5 years to 2 years time it was able to spread across most of the countries in the world. After reaching that goal, what has done this virus is it start replicating very quickly inside those humans. Because of very quick replication, it was able to generate mutant strains within a short period of time, which can more efficiently transmit the disease from one person to another. And because of that, at once lot of people are getting infected, and in some instances the variants like delta and alpha, they are more deadlier than the wild type of the virus as well. So first stage, the virus was able to very strategically, it was able to spread the disease to the most of the countries, and like gorillas, after strategically placing in many countries, now they have started attacking human beings. I just want to elaborate on one word here, which is called the R note of an infectious diseases. You may think, now for last 3 years we are not able to, I mean even the biggest countries in the world, they were not able to tackle this threat in a very successful way. So you may think it might be the deadliest virus we have ever faced, but unfortunately I have to say this is not the deadliest, or this is not the most complicated virus we have ever placed. So because if you see the basic reproduction number, or the R naught, which means number of people getting the disease from one infected individual. So if a virus or if a microorganisms want to generate an outbreak, so this R naught value should be more than 1. So the virus, if a person get infected, this person should infect more than one person to make it an outbreak, right? But if you see COVID-19 R naught value was initially 3, and with this Delta variant it has become 7. But you can clearly see here the chickenpox has R naught value of 10, and if you see mumps, it has R naught value of 12, and if you see measles, it has R naught value more than chickenpox or mumps. So when it comes to the R naught value, COVID-19, even with the Delta variant, it is not the most infectious bug we have ever met. And then with the R naught value, we have to see the case fatality rate of a disease, and it would be the same. Here you can see in this y axis, it is the case fatality rate. You can clearly see it ranges between 0.1 and between 8. But if you see the MERS or the Ebola or the Spanish flu or even the polio, smallpox, they are more deadlier than this COVID-19 virus. So I have mentioned few points that there were several reasons why it has become a pandemic. One of the another reason why it has become a pandemic is these super spreaders and the super spreading events. So super spreaders mean there are some people who get the disease, they excrete virus in abundance, So the people who have close contacts with these super spreaders has a more chance of getting the disease. So if 100 people get infected this virus, around 10 to 15% become super spreaders. So they are the one who mainly spread the disease in the community. I think now I have to talk about these COVID-19 variants. It is a special hot topic. As I said before, when the vaccines were invented at the beginning, all these vaccines basically targeted the wild type of the virus. As usual, in all battles in nature, if you talk about antibiotics, when we are trying to introduce a new antibiotics, the bacteria will hit back with the resistant mechanisms. The viruses are the same. So when human beings or when scientists were trying to invent many vaccines to defeat this virus, again virus hit back. So that is the variance. So now the biggest question asking by lay people and all this and even the scientists, are these vaccines going to work against variants? Before going to talk about that topic, we will see what are variants and what is the classification of variant. So variants occur due to mutations of spike proteins. When these RNA viruses replicate, there is a high chance some of their proteins, especially their spike protein, to get mutated. So some of these mutations, some of the changes happening in the spike proteins actually increases the binding to the host cells. Because of that, they spread disease more clever than they spread the disease more cleverly than the wild type. So the WHO has a criteria for these variants, that is mainly three: variants of interest, the variant of concern, and variant of high consequences. So the features of variant of interest are they may drive surges, that means their transmissibility can be more, they may be more contagious, and the reducing the immunity is a possibility, and the impact on testing and treatment it can reduce, and there are a lot of variant of interest circulating. During this pandemic, there are a lot of viruses which are variant of interest. Our main concern is here of variant of concerns, because there is a possibility they can cause more severe disease, they can be more contagious, actually they are more contagious, and they can reduce the immunity, and they can impact, they can have impact on testing and treatment, and there are few variant of concerns, which there are 5 actually variant of concerns, and there are many more to come. I will describe them later in my slides. And the last but the most important one is variant of high concerns, which can cause more severe disease, more hospitalization, but fortunately at the moment we don't have any variant of high consequences at the moment. So what are the main variant of concerns? The first one is alpha, as you all know, which was originated in United Kingdom September 2020. Then beta, which was originated in South Africa May 2020. And the third one is gamma, which was originated in Brazil November 2020. And the last one is delta, and this is the most predominant circulating virus variant at the moment, which was originated in India. And there are few other variant of interest which called eta, lota, kappa and lambda, and here we have the scientists have given a special attention to lambda, which has been originated in Peru. So when it comes to the diagnosis of COVID-19, still the definitive diagnosis is RT-PCR, but we can use antigen detection and antibody detection as well in some instances. But I have to mention few points here about the diagnosis. That is, this disease has been in the world for nearly now 2 years. Even in Sri Lanka, we had this third wave originated in the April of 2021. So now nearly for 5 months we are living with the disease. So because of that, in the community we can see lot of people who has actually got the disease unknowingly, and also there are considerable amount of people who are coming to the hospital who had got the disease previously. COVID-19 infection is there and it is going to stay with us for a while, and meantime the people will get other diseases as well. Because of that, sometimes though the RT-PCR is the most definitive and most sensitive test, with the current context, I am seeing when this RT-PCR testing is performing unnecessarily, it is more harmful to the patient than it is a help for the patient. Because I have seen when this RT-PCR test is performing on the people who are asymptomatic for the COVID-19 infection, still you can get a positive results. There are some cutoff points. Now, for example, according to the Ministry of Health guidelines, if the CT value is more than 30, it is highly suggestive of a past infection. Unfortunately, in the real world, I am seeing even with the past infection, sometimes you can get CT values around between 25 and 30 as well. Because of that, actually, most of the time when I am issuing the report, I have to have a very good dialogue or the clinical conversation with the consultants before issuing the results. Because sometimes patient is coming with abdominal pain, but he is positive for RT-PCR with a very high CT value, but his main problem is his acute abdomen. So we have to give the priority for his acute problem. Otherwise, definitely the number of non-COVID deaths happening during the COVID time period will increase. Because of that, sometimes though the sensitivity is less in clinical context, sometimes antigen test, sometimes some instances antigen test can be more useful than the PCR test. Another thing is, just to elaborate on the PCR test, this is not a simple test, this is very complex. The basic principles of diagnosing COVID-19 infection by using PCR is, in the same test, we are trying to find out two different genes which is specific for the COVID-19 virus. To give the COVID-19 PCR test as positive, we have to confirm two specific genes are available in the patient's sample. And other most important thing I have to tell you, when we are performing PCR testing, we get lot of samples from the community and we are dealing with very tiny biochemical molecules which easily can contaminate the environment. So when you are performing lot of tests at a time, you can cross contaminate the other patient samples who are actually negative. So my advice for you is, when this pandemic, when you are getting lot of persons with COVID-19 infection, if you have any sort of a doubt on clinical grounds about a positivity of a PCR test, please call the microbiological department, because laboratory errors can happen and it will happen. And sometimes I have seen some instances, not in government laboratories but even in the private sector PCR laboratories, they have issued wrong reports. So always the clinical picture, use it as a guideline even for the PCR testing. because laboratory errors can happen. I am not going to talk about the management, but I have to mention one thing here. I know we are getting a lot of persons with COVID-19 pneumonia, and WHO strongly recommend to use systemic corticosteroids if the patient is getting a severe pneumonia and it has scientific evidence. If you reduce this inflammation, there is a high chance you can reduce the mortality as well as complication. But as a microbiologist, during last 1 to 2 months, I have seen because of the overuse of steroids, we are getting lot of secondary infections in COVID-19 patients. I have seen several patients actually having COVID pneumonia complicated with candida pneumonias, and also sometimes because of the overuse of steroids, even you can get candidemia. And especially in tropical countries like Sri Lanka, when the lung get damaged, it is quite easy to infect with aspergillus like fungi, which are very virulent as well. So I think when we are managing the patients, we should have a multidisciplinary approach. I think it is very critical to know when to stop corticosteroid, because sometimes we have kept the patient in the ICU for nearly 1 month, but unfortunately they are going to die not primarily due to the COVID pneumonitis, but due to these secondary infections. I will now touch on these vaccines. As you all aware, when it comes to the COVID-19 infections, mainly there are 3 vaccines. One type is called the inactivated vaccine. The second type is viral vector vaccine, and the third type is mRNA vaccines. So when it comes to the inactivated vaccines, as you all know, it is the inactivated virus. So it has lot of antigens in the vaccine itself, and when it is injected, our human body will produce lot of antibodies against all these antigens. So they will produce antibodies against this protein as well as other antigens which are in the virus as well. But unfortunately, usually inactivated vaccines produce their immune response is not robust. Because of that, if you are going to get a vaccine like Sinopharm, which is an inactivated vaccine, you should get the second dose to have a good immunity. And especially when there are variants of viruses are circulating, you should have a good antibody level to prevent the disease. And as I said before, most of these viruses actually are not good in preventing the disease, but they are very good in preventing the severe disease. So because of that, if you want to prevent the severe diseases, if you want to prevent that you are getting a severe disease, you should have the second dose, especially for inactivated vaccines. And the second type is viral vector vaccines. There are mainly 3 types of viral vector vaccines. One is Covishield vaccine, AstraZeneca, Oxford AstraZeneca. The second one is Sputnik vaccine, and the third one is the Johnson vaccine. It is the same. Initially, when these vaccines were introduced, all the studies showed very promising results even with a single dose. But now the whole picture has changed because of the emergence of this variant. So it is very important to have the second dose, and you should have the adequate amount of antibodies to prevent the severe disease. And the third type of vaccine is called mRNA vaccines. I have to mention, this is the first time we have used as humans mRNA vaccines to tackle an infectious disease. So there are mainly 2 mRNA vaccines. One is the Pfizer vaccine, another one is the Mrna vaccine. So I think this is one of the hot topics in today's scientific world. So we thought at the beginning, when the vaccines were introduced, we are never going to have breakthrough infections. So we expected breakthrough infections are going to be minimal. But the viruses, they are very clever. They got various type of mutations. So because of that, actually we are seeing lot of breakthrough infections. So the no vaccine is 100% effective. Infection occurring after the adequate time for the immunity after all recommended doses of vaccines we call a breakthrough infection. But fortunately still majority are asymptomatic or have the mild infection, but there are some fatal cases have occurred. But the take home message is, if you get the vaccine, the chances of getting the severe disease is very less. And I have to mention, all these vaccines are safe. All the WHO approved vaccines are effective. All will reduce the risk of severe infections, and most of the vaccines are still give promising results, preventing severe disease from variants. So the best vaccine for you is the first one you get. So the last message would be, variants will continue to arise, primarily increasing transmission, evading immunity from natural infection or vaccine immunity. Vaccines continue to have high effectiveness in preventing severe disease, but do not completely protect against, but likely reduce asymptomatic infection. IM injection vaccines are not ideal in inducing mucosal immunity and thus completely preventing infection. Natural infection, and in future intranasally administered vaccines may be required to block the asymptomatic infection and transmission. Vaccine breakthrough infections occurred but are mainly mild, may be associated with some transmission, but still generally they less transmissible. So the take home message is, it is now proven when it comes to reducing the transmission, all these vaccines have gaps, but when it comes to prevent the severe disease, they all are good. So because of that, my answer to the first question, in this post vaccination era, where are we heading to? But unfortunately I have to say, for next couple of years or maybe next 4 to 5 years, this disease is going to stay with us. And even with the vaccination, some of the people who have comorbidities, they will die. So we have to accept this reality, because if you push the panic button, and all the other infections, all the other diseases will also occur in this world. So if you press the panic button, definitely the number of COVID deaths will also increase, and also the non-COVID deaths will also increase. So we have to be very, very pragmatic. We are in a very complicated, serious situation at the moment, whole world. So as a professional, I think we need to get together. We need to get together, and we have to find out a more pragmatic and a practical approach to both to prevent the COVID related deaths as well as non-COVID related deaths. Thank you very much.
Thank you, Muditha, for that excellent talk. So now the forum is open for some questions. Muditha, can you come forward and...
More question about the PCR. Now, I think that sometimes PCR is positive for weeks. Now, even some patients with the severe oxygen dependent patients, they excrete either virus or PCR, the RNA. Now, we see sometimes like even the weeks, like 3-4 weeks, again, the PCR is positive. Is it due to excretion of whole virus or just the excretion of RNA? But it is a very good question. So there are different theories actually behind that. Initially, we thought it might be some RNA particles, but to detect it in the PCR, it should contain the genes we are looking for. So some instances actually I have seen even after 4 to 6 weeks after the initial infection, both genes can be detected through the PCR testing. So it has to be a viral particle which contains both genes. And some instances actually, after the infection, I only see only one gene. So it is mainly viral particles. But having said that, now there is a theory coming, is this virus has intermittent shedding. So as I shown in one of my slides, these AC2 receptors are not only, it is not only in the respiratory tract, but it can be found in the other organs as well. So I know this is RNA virus. Usually these dormant forms are usually in, like herpes simplex virus or adenovirus or cytomegalovirus, usually DNA virus. But there is a theory behind now. Actually, there might be an intermittent shedding. So to be frank with you, I don't know the exact answer. So if it is intermittent shedding, actually it has to be the total virus. So that is a one possibility as well. Another thing is, recently I have seen one patient actually coming who got the disease about 1 year ago. And when the surveillance was done by the infection control, actually they have missed that he got the disease previously. So they have done the PCR on this person as well, because he was a close contact of another infected person. So his PCR also became positive, and the CD values were around more than 30. So, I mean, initial thought was it is only the viral particles, but I have a strong feeling it might be intermittent shedding as well. And also, in the current context, actually we are very lenient on discharging. Basically, if the patient is asymptomatic after 10 days, we are discharging. But I have seen some patients actually, when we do perform the RAT, it became positive. But with the current context where the disease is more prevalent in the community, as I said in my lecture, we have to be pragmatic. So there may be cases who are actually spreading the disease in the community, who have already got the disease, but we can't care them actually at the moment, because I mean we have to discharge the patients as quickly as from the hospital, because the acute severe cases are more. There is a possibility they might be infectious, because my argument is now we got Delta virus, and even the countries like Australia also got the Delta virus. So it is I mean we have many people think we got the Delta virus from India, but virus is so independent. Once they have conquered the whole world, they have their own cycle. So any variant can occur in any part of the world. So my feeling is they might be infectious as well. And it can be very, very low infectivity, but once the time goes on, I mean, it can cause a major outbreak. But it is not still scientifically proven, but with my PCR experience, I think there can be actually active virus, whole virus also can be shedding.
Some more questions, Muditha. What is your opinion on third dose of vaccine for healthcare staff?
Yeah, that is also a very hot, arguable topic. I just went through the CDC guideline just before coming into the lecture. And according to the CDC guidelines, they are only recommending a third dose for moderately or severely immunocompromised patients. Actually, they have recommended after 1 month of getting the second dose, they have recommended to give the third dose. So the argument here is, now as I mentioned in my lecture, all the vaccines, they are very good in preventing the severe disease, but unfortunately they are not good at breaking the transmission, because all these IM vaccines, they are not good in inducing the nasal immunity. So we need to have a very good nasal immunity, which is mainly driven by IgA antibodies to prevent the disease. Now, initially, all these vaccines were actually produced against the wild type. So basically, at that time, the antibody levels, they had a considerable, the antibody levels in the blood was successful in preventing the severe disease. But the number of breakthrough infections
now we are getting is more. So actually the scientific world, they are puzzled why we are getting so much of breakthrough infections. So one argument is they are thinking, as we all aware, they are thinking with the time, the antibody levels are waning. So if we are going to boost up the antibody level, are we going to reduce the disease severity? So if it is so, actually we should go for a third vaccine. But the other argument is, as I mentioned before, anyway from the beginning, these vaccines were not good at preventing the disease. So are we seeing the true effectiveness of the vaccine? Are we going to stop the breakthrough infection after giving the third dose? Nobody knows. That is the other argument. Another thing is, if you take the whole world, I mean, there are a considerable amount of countries where they haven't even had a single vaccine. So we have to balance those two. But with the current context, I think with the years to come, we have to go for a third dose. That is my basic understanding. And even I just had an article which was written in Israel. Actually, they were thinking about giving a fourth dose actually. So I can't give a very concrete answer, as I said before, because we don't know why we are getting breakthrough infections. Or is it due to the ineffectiveness of the vaccines from the beginning, or because of the weaning of antibodies?
So, few more questions, Muditha. I'll ask you short ones. What is the optimal antibody levels?
Now, actually, we are lucky to have the antibody testing facility in our biochemistry department. And I had a chat with Dr. Dilinika as well. So according to it differs according to the testing strategy we are using. So the one we are using actually give an antibody level. If it is more than 1, then it has the required amount of antibodies. But having said that, I didn't do a research, but what I have seen is the persons who got severe pneumonias, actually, they have the antibody levels more than 150. And most of the persons who got vaccines, majority of healthcare workers got the Oxford AstraZeneca, their antibody levels varies between 1 and 10. Actually, most of us has antibody levels between 1 and 10. But occasionally I have seen some doctors has got vaccines and their antibody level is around 30. But the persons who got mild disease, I have seen antibody levels, between 30 and 100. So nobody knows the exact protective levels, but according to the current guidelines, basically, if the antibody level is more than 1, we have to take them as having some sort of the protection against the severe disease. But as I said before, we don't have any cut-off points, and as I said before, anyway from the beginning, these vaccines were not effective in preventing the disease. And recently, we had our College of Microbiology sessions, and I have to say, even the Professor Malik Peers said, at the moment, with the current evidence, basically this is natural selection. Whether we like it or not, this is natural selection. So at the moment, the most protective persons from these COVID-19 infections are the ones who got the severe disease. And another thing is, if you get the mild disease and if you have already got 2 vaccines, they are also protected. And the persons who got only the vaccine but not the natural disease, they are also to some extent protected. And the most unprotected persons are ones who haven't got any sort of a vaccine. So there are no any clear guidelines about the level of protection from the antibody levels.
What is the most suitable vaccine for children less than 16?
Less than 16. Yeah, WHO recommends. Basically, they in USA they have used Pfizer for about 12. But when we talk about Sinopharm or Moderna, we don't have data. But even in Sri Lanka, actually, they are promoting to give Pfizer because it has tried in USA.
Right. I think final question. If a patient after a disease, does he need a vaccination? Does he have active immunity which prevent recurrent infection?
Yeah, at the moment, as I said before, if you get a severe pneumonia, the evidence for having evidence to get a reinfection is very, very less. And even if you have the mild infection, evidence for reinfection is very less. But we do recommend even the persons who get the severe disease to get a vaccine after 1 month.
One more appearing. Place for mix and match of vaccine.
I think it is also going, as I said before, then we have to decide whether we are going for a third vaccine or not. If the answer is yes, and the scientists have suggested to mix it actually with a different type. For example, if you have given a DNA vaccine, then you have to go for RNA vaccine. So for the mixing, there are scientific evidence, but first of all, we have to decide whether we are going for a third vaccine or not. And it is strongly recommended if you have taken AstraZeneca vaccine not to get the third dose from AstraZeneca vaccine because it is an Adenovirus virus. So there is a theoretical possibility your immunity can drop with the third dose. So the mixing is a possibility.
In absence of any more questions, let me conclude and present the certificate appreciation to Dr. Mrna Abeykoon for an excellent presentation on the topic of post-COVID-19 vaccination era, where we are heading to. Thank you very much, Muditha. Great honor to be here and then accept our application. I would like to thank the sponsors today, COCA, providing meals, and then PND Consultant Consortium, Mr. Prasad Disanayaka, to handling and this hosting this meeting, and Merck, Shakul and team providing us these certificates and posters and all. So last, I would like to thank you all to come here and participate this event. So I hope that you learn a lot from this. We'll see you next time as well. Thank you.